Welcome to Bullet Point Nursing. In this lecture, we're going to go through the foundations of what you need to know for your med-surg or adult health class for your RN for the musculoskeletal system. Some schools call this the bone and joint section. We're going to go through this as we always do. We're going to go through anatomy and physiology. We'll go through assessment and diagnostics, and then we'll get into the diseases. Again, we're going to go through all the basic high-level overview so that when you get into class, you're fully prepared for it. Plus, you can also use this as a great review as you're preparing for the NCLEX. So let's go ahead and get started on the anatomy and physiology of the musculoskeletal systems. First, bones provide structure. So that's our skeleton, and it provides the structure of our body. That's the form that we have. It also serves to protect our organs, such as the ribs, which protect our heart and lungs. The bones also store minerals. Very famously, they store calcium, which we're going to talk a bunch about in musculoskeletal. And they also have a role in producing blood cells. Hematopoiesis, or the production of red blood cells, happens in our bones. Next, we have our joints, another big part of the musculoskeletal system. Joints allow movement. There's lots of different types of joints. There's joints that don't move. There's joints that move a little bit, and there's joints that are freely mobile. Within that, as you for sure remember from anatomy and physiology, within the different movable types of joints, we have the ball and socket joint, we have hinge joints, we have several different types of joints. I think that's a little too basic for you, so we're going to move past that. I know you already know that. Next, we have our muscles. There are three different types of muscles. Really quick, we have skeletal, smooth, and cardiac. Cardiac only exists in the heart. Skeletal are all the muscles that we can voluntarily control. And then smooth is the involuntary muscles, such as those within the GI system that we do not voluntarily control. We have tendons and ligaments. It's important to know the difference between these. Tendons connect muscle to the bone, whereas ligaments connect bone to bone. Bone mass, which is something we're going to be talking about when we get to osteoporosis, bone mass decreases with age, which is what puts you at risk of osteoporosis. But the important thing to know right off the bat is that decreasing bone mass puts you at an increased risk of injuring yourself. Okay, and specifically, we're talking about fractures. Next, it's important to understand before we go any further, calcium. Calcium is the most important element for the contraction of muscles. Okay, so this has nothing to do with anything else, but calcium, in addition to being one of the most important things inside of bones and contributing to our bone strength, calcium is one of the most important elements for the movement of muscle. And this applies to all muscles, both voluntary and involuntary. Moving along, bone remodeling, the way bones are developed and evolve, is controlled by osteoblasts and osteoclasts. One builds them up, one breaks them down. These are regulated by the parathyroid hormone, by calcitonin, and by vitamin D. Next, we have our musculoskeletal assessment and diagnostics. So first, when you inspect the patient, when we assess for a musculoskeletal injury or illness, we're going to start with inspection. We're going to look at the affected area or the entire body. We're going to look for deformities and swelling. We're going to look for asymmetry, meaning one side of the body is different than the other. Always a good note to check in real life when you're checking, let's say, a sprained ankle or anything like that. You're always looking at both, not just the one that the patient's complaining about, because we want to compare them. You're also going to look at discoloration. You're going to look at their gait, which is how they're walking, and their balance. There is something called, it's not commonly taught in nursing, but it's a great thing to know, and it's from trauma EMS. I'm a paramedic, so I teach this, but DCAP BTLS. And that stands for deformities, contusions, abrasions, penetrations. Deformities is something that appears abnormal. Contusions are cuts. Abrasions are scrapes. Penetrations are puncture wounds. And then it moves on to burns, trauma, lacerations, and swelling. So again, that gives us a really full image of what we should have in our mind when we're examining any area of the body, specifically the skin, specifically musculoskeletal, specifically for signs of trauma. That covers everything that we're looking for. Palpation. Once we inspect it, now we palpate. When we palpate, we're checking for bruising, we're checking for tenderness, and we're checking for crepitus. The big thing that we're looking for is their pain. Okay, so palpation, we're very often looking for pain. Do I assess pain, or do I stimulate pain when I palpate somewhere? And also, as I'm palpating, does it feel normal in addition to how it looks? Neurovascular, that's going to involve the neurological system as well as the cardiovascular system. But in terms of musculoskeletal, that includes checking their pulse, their motor, and their sensation. So we usually use the acronym CMS, circulation, motor, sensation. Circulation is, do they have a pulse? Motors, are they able to move it? Sensation, are they able to feel in that extremity? Next, we have ROM, or range of motion. This is where we do active versus passive, and this is a big part of your musculoskeletal chapter. And range of motion is where we go through every single joint, joint by joint, from the most distal aspect of the phalange, the finger, all the way down to the bigger joints in the shoulders and the hips, and all the way back down the arms or legs, depending where you started. And we do this two ways. We do it active and passive. And real quick, because you absolutely have to know for testing purposes the difference. Active is where the patient does it. Passive is where the patient goes limp, and I go ahead and I move every single joint that they have to test again for the mobility. So there's active and passive, big part of musculoskeletal, and this goes through every single joint, biggest to smallest, neck, shoulders, hips, fingers, toes, everything. And active is where the patient does it. Passive is where I do it. When you're doing this in skills lab, you'll often have that your teacher, or you're going to demonstrate it to the patient, and then you're going to do it with them. So you're going to say, I'm going to go ahead and do a range of motion assessment with you. Go ahead and do as I do. And then you're going to say, we're starting with our fingers. Go ahead and go like this, and then like this, and then like this, and then flex, extend, and we're going to go through the entire motion. Next, we have our strength testing. This is graded on a scale of 0, which is inability to grasp or move or anything towards the motion of gripping, versus 5 is full strength of what you would expect in your patient. So again, 0 to 5, 5 is what we want. 0 would be no muscle contraction whatsoever. Arthrocentesis is a procedure in which a needle is put into a joint in order to aspirate, in order to pull out fluid, specifically synovial fluid. That's the fluid that's in our joints. And it's used for diagnostic purposes if we're not sure if there's an infection there, or therapeutic purposes. If we know there's an infection, we need to get rid of it. So those are the two different things. Again, something that you should know in arthrocentesis. And then imaging in labs. We also use x-rays. That's very basic. We use that to check any bone in the whole body. We can check if it's broken with an x-ray. I think there might be an exception or two, I'm not sure. MRI is where we use to assess soft tissue. We also use that for other things, but it's not counted to musculoskeletal. We have a BMD, which is a bone mineral density test, and we use that for metabolic bone diseases like Paget's disease. We also have something called a DEXA scan, or a bone density scan, and that's what we use for osteoporosis. In fact, that's commonly done on a routine basis or as part of one-time screening for patients that are at high risk for developing osteoporosis. Then we have ESR or CRP. Those are labs. You've probably heard those in the past. One is called a SED rate. One is called a C-reactive protein, and those assess for inflammation. Those would be for things like rheumatoid arthritis. And then we have uric acid, which is gout. Gout may or may not be covered in your lecture for musculoskeletal. We're going to go ahead and cover it here today, though. Moving on. Next, we have fall prevention. So a big part of musculoskeletal is going to be preventing falls. So crutches support your weight on your hands, not on the axilla, not on the armpit. So when you're educating a patient on how to use their crutches, we have to educate them. Even though it looks like the patient is leaning on their armpits, they're not. Their weight has to be on their hands. Next, you should educate the patients to place the crutch 6 to 10 inches in front of their foot. Their elbows should be flexed, and that's the way they should move. There's a bunch of different types of gaits that you're going to be responsible for teaching your patients how to use with crutches. There's a 2-point, 3-point, 4-point, the swing to and the swing through. I'm not going to go through all those. This isn't a skills lecture. This is didactic, but you are going to be expected to know those. There are a bunch of great YouTube videos, not from us, that you can just search if you want to see all the different types before you get into your classroom. Next, when we use a patient's cane, you're supposed to stand on the patient's affected side. You may see differently, by the way, on which side you're supposed to stand on. So I put the affected side because that's what most of the textbooks say, but you may be told the other way. Go with what your school tells you. Next, elbows should be flexed. The cane should be on the unaffected side. Okay, the cane is always held on the unaffected side. And the reason for that is very simple. When the patient is stepping on the unaffected side, they don't need to use the cane. It's when they are stepping on the affected side that they should be using the cane for support on the unaffected side. So if my right foot is the problem, I hold it on my left side so that when I'm stepping with my right foot, I have support on my left side with my cane. So again, canes, elbows should be flexed. Hold the cane on the unaffected side. So the opposite side of the issue. Next, home safety. Remove any loose rugs or secure them with non-slip backing. Ensure good lighting, especially in hallways and staircases. Keeps floors free of clutter. Watch out for cords and other tripping hazards. Install grab bars in the bathroom. All of this is very basic stuff, but again, a lot of this is fundamentals that you would have learned in your full prevention and full risk part of fundamentals, but sometimes some schools included here in musculoskeletal. So I did put this one paragraph here, just a refresher. Next, orthostatic hypotension is where a patient's blood pressure suddenly decreases when they go from a laying down or seated position up to a standing position. It's common with a bunch of different medications that you probably learned about in pharmacology, but you really need to educate patients because they become a big full risk if they get up too quick and they develop orthostatic hypotension. One of the key factors of this is that they fall down and pass out. So this is definitely something that you have to assess for. Next, we're going to move on to the specific diseases, and we're going to start with fractures. So when we talk about fractures, let's begin with the patho. The patho is that there's a break in the bone caused by trauma or bone decalcification, which would be the osteoporosis. Most of the time, we're talking about trauma. There is also a third thing, even less common, and that's where a tumor has caused, if they have osteomyelitis, if they have bone cancer, that the tumor could also cause the patient to end up with a fracture. But by far, most commonly, especially on the NCLEX, most of the questions would be trauma related. So a fracture can be classified as closed, that's your basic fracture. Open, where the wound area, the injury area is the skin is open, usually where the bone is poking through. There's transverse, oblique, spiral, comminuted, green stick, pathologic, and stress. All of these are probably covered in your anatomy and physiology class. Usually we don't go too deep into them again in your med-surg adult health class, but you are expected to be familiar with these, so I did include them. If you're not familiar, go ahead and refresh yourself. Next, the presentation of all of these is obviously going to be pain. It's going to be tenderness at the site of injury. There's going to be instability of that extremity or of that bone or that bone area. There might be crepitus, which is two bones rubbing against each other. If you've never fully understood what that is, crepitus is the sound of two bones rubbing against each other. Deformity is where something is abnormally formed or abnormally situated at this moment. And then edema, which is swelling, and bruising, which is like a black and blue mark, which we call hematoma or ecchymosis. Next, a fracture is diagnosed based on x-ray. We do have other things that can diagnose it as well, but x-rays are go-to. It's the simplest, easiest, cheapest. The management is almost always going to be to immobilize the fractured bone and to ensure that the patient has good pulse, good motor, and good sensation distal to the fracture. So if the patient has, let's say, ankle fracture, we always got to check their toes to make sure they do have good circulation at that extremity, that they still have sensation at that extremity, not just from the injury. Also, if we're putting a cast on, we also definitely have to make sure that we're assessing their pulse, motor, and sensation both before we put on the cast and afterwards. Nursing notes over here, I have that strains are excessive stretching of a tendon versus a sprain is excessive stretching of a ligament. So remember at the beginning, we talked about tendon versus a ligament. That's the difference between a strain and a sprain. I really don't think the NCLEX would test you on the difference between these two, especially since most of the public doesn't know the difference, but your school might, so definitely be prepared for that. Either of these are treated with RICE, rest, ice, compression, elevation. You've probably heard that since it's a kid. Hasn't changed. It's still the same thing. Next, we have traction. Traction is where we pull on an extremity in order to realign a broken parts of a bone. So for example, if a bone is broken like this, we pull traction is where we pull until they're back in line again. That's what pulling traction is. And we use it to realign our bone. And once we have done that, then we would go ahead and immobilize it. Once we've reduced it, it's called, once we got rid of that issue where it's not in perfect alignment. Reduction is the manipulation to achieve bone alignment. We just discussed that. Casts immobilize fractures, and there's lots of different casts, and this actually is not even that recently anymore. For the last many years now, this has become a nursing skill where nurses can actually apply casts, which used to not be within the scope of nursing, but it is now. Wet plaster casts dry in 24 to 72 hours. That's probably what most of you are familiar with when you think of a cast, but especially if you work in the ER, we have a lot of other different types of casts, such as air or fiberglass, and there's even a bunch more than that nowadays. I didn't include a full list here. Make sure before you put on a cast, you do a skin assessment and document that skin assessment, especially if it's the plaster cast that's staying on for a few weeks. You must have a skin assessment done beforehand so that we know what the situation is before that cast went on, in case anything goes wrong while the cast is on. Next, there's something called a fat embolism. This is commonly tested on in nursing school in regards to fractures. It's where fat particles enter the bloodstream and end up with a pulmonary embolism. Now, the interventions for this is going to be to give them oxygen therapy, to prevent this in the first place by properly immobilizing fractures and treating them. And if this does get the patient does get into this situation, we're going to administer fluids and anticoagulants in order to treat that fat embolism. A lot of times this will depend on what's going on. Anticoagulants may not directly address a fat embolism. Again, it's fat, it's not a clot, but that's what your textbooks say, so that's what I put in there, but it's a lot more complicated than that, but this is something that's commonly tested on. Most of the test questions I've seen in the test banks I've reviewed are based on the fundamental of what is a fat embolism and who's at risk for it, and it's the fat particles enter the bloodstream, and it's a patient who has fractures or long immobilization. Next, or in general, that had issues, complications relating to fractures or related to the immobilization due to those fractures. Next, we have DVT and PE. DVT is a deep vein thrombus, and PE is pulmonary embolism. Patients with fractures are at high risk for developing these. In this case, it's due to immobility. Anytime a patient's immobile, they're always at risk for developing a blood clot, because part of what keeps our blood from clotting is our mobility, is our movement, is our always being active. As soon as that stops, we become at risk for developing a blood clot. The prevention here is to ambulate patients as early as possible. We never want prolonged immobility if possible. We may put them on an anticoagulant to avoid that, and we may use compression devices such as SCDs in order to keep that extremity moving during the recovery process. Next is something called compartment syndrome. Compartment syndrome is an actual medical emergency. It's a really big deal, and it's caused by an increase in swelling within an extremity, but the swelling has no place to go, so it starts to crush the actual extremity itself. So picture if you have swelling right over here, but instead of expanding outward, it starts to crush inward towards the vessels, the nerves, the muscle, the bone. That's what compartment syndrome is, and the biggest issue here is that it crushes your blood vessels, and now it can actually cut off circulation, similar to as if you had a tourniquet on there. The signs of this include extreme pain, that it doesn't look that bad, but it hurts like heck, where the area becomes pale because it doesn't have any more circulation. It has paresthesia, which is numbness, because again, it doesn't have circulation. And obviously the final sign of this is where they have no pulse in that extremity. If this happens, you need to immediately take off whatever dressings they have on there. And if there's no dressings on there, it's just the skin itself that has become so taut and tight, and now it's crushing inward. In that case, the patient's going to be what's called a fasciotomy, which is where they slit the skin open and allow the area under there to have the swelling, to have an area to escape instead of crushing down on the blood vessels. Moving on, we have osteoarthritis. Osteoarthritis is often compared to rheumatoid arthritis, but OA is more common, so let's start there. The patho is that it's a degenerative disease of the articular cartilage. It's commonly referred to as a wear and tear disease. The classic presentation, and this is often, especially in test purposes, compared to RA. So let me go through the comparisons, and I won't cover this a second time when I get to RA in just 2 minutes. So osteoarthritis is asymmetric joint pain versus rheumatoid arthritis is symmetric joint pain. Osteoarthritis is mostly in the larger joints versus RA is mostly in the smaller joints. And then osteoarthritis is worse with activity versus rheumatoid arthritis gets better with activity, surprisingly, but it's based on the pathophysiology. One is a wear and tear, where the more you use it, the worse it gets. Rheumatoid arthritis is inflammation, and the more you use it, the better it gets. There are two things that are often tested on with OA, that's Bouchard's nodes and Heberdine's nodes, and both of those are classic symptomology of osteoarthritis, nothing to do with the how bad the disease is or anything, but those are both testable items on the assessment of a patient with OA. If you see either of those in a question, your patient has OA. These are diagnosed based on presentation, based on an x-ray, and sometimes they'll do a biopsy or other tests to rule out rheumatoid arthritis. How do we manage it? We manage it with weight loss, we manage it with physical therapy. Yes, we actually do want these patients to do more exercise. That'll help. We often give them over-the-counter medications such as ibuprofen if needed. And, I'm sorry, actually, I shouldn't say that because very often we give them acetaminophen, which is Tylenol rather, but sometimes it's ibuprofen. I'm going to stay out of that. I shouldn't have said which one we give because that's a big debate. Anyways, the definitive treatment for this is surgery. In fact, if you've been on a ortho floor in any hospital, most of those right hip replacements and left knee replacements and right knee and all of that, almost all of those come from osteoarthritis. Moving on down, we have our nursing notes, and that's just simply to monitor for fall risk. Finally, or not finally, but moving on, we have rheumatoid arthritis, which is the other half of this disease. It's two totally separate diseases, but in nursing school, we always bunch them together. So the path over here, this is an inflammatory disease. This is an autoimmune disease. Remember those two things. This is an inflammatory autoimmune disease. And again, we gave the presentation. This is symmetrical issues This is stiffness in the smaller joints instead of the bigger joints, and this is worse in the morning instead of worse with activity. These patients can also have systemic signs and symptoms because it's a systemic disease. It's an autoimmune disease. They can have fatigue. They can have a low-grade fever. They may have weight loss. They're almost always going to have their labs show a high ESR and a high CRP because those are both inflammatory labs. These are diagnosed based on, we have a test for it. It's the rheumatoid factor blood test. We use that. Plus, we would x-ray the actual joint. And very often we would do a biopsy as well. Sometimes we can diagnose it without that. The management over here is going to be physical therapy. That's first and foremost. We want range of motion exercises to keep their joints active. We use a lot of heat and cold, whatever helps the patient for their comfort level. We also use NSAIDs, which are the ibuprofen. In this case, Tylenol or acetaminophen would be a wrong answer because this is an inflammatory disease. So we want an anti-inflammatory medication such as NSAIDs. We also use DMARDs such as methotrexate, hydroxychloroquine, and then we can move on to the really fancy DMARDs like adalimumab, which is Humira and things like that. And finally, for flare-ups, we may use steroids such as your basic Medrol dose pack or prednisone, something like that. Nursing notes over here is to monitor for anemia. In the part of the pathophysiology of rheumatoid arthritis is these patients are at increased risk of developing anemia. Moving on to osteoporosis. We referenced this way back at the beginning of this lecture. The pathophysiology over here is that the bone resorption, where the bone reabsorbs calcium and fortifies itself, exceeds bone formation. Or I'm sorry, I said that wrong. Bone resorption, where the body loses the calcium from the bone, exceeds the bone formation, is greater than the amount of calcium that the body uses to fortify itself, to fortify the bones. So this leads to decreased bone density, decreased bone mass, and the main issue here is the increased fractures. That's the main issue you'll be tested on. What is the issue with osteoporosis? Because other than fractures, it doesn't really have any presentation. It doesn't have any symptomology. The issue is that they become at risk for fractures, and they come in with fractures more often than anyone else. So that becomes an issue. More often than someone who doesn't have osteoporosis. This is diagnosed based on a DEXA scan, which is a bone density scan. It's managed with bisphosphonates. That's going to be the first line treatment. We can also use SERMs like raloxifene. There's a lot to know specifically about bisphosphonates, very interesting pharmacological category. I'm not going to go into it here. We have the farm videos for that. But just so you know, those are the different options. But we don't really have a definitive treatment for it other than this. And even these treatments, they're not meant to be taken for the rest of your life. So it becomes a delicate balance of how to actually manage this disease. This is primarily an age-related disease, or it can come from medications. Two famous medications that cause an increased risk of osteoporosis. One is steroids, and one is PPIs or proton pump inhibitors. Both of those place a patient at risk for osteoporosis. In both of those cases, as well as everyone who's taking who has osteoporosis, you're going to educate them on the need to supplement with calcium and vitamin D. We're always going to teach these patients fall prevention because of that increased risk of developing fractures. Finally, we're going to end off with gout. Gout is an inflammatory arthritis caused by uric acid crystals depositing in the joints. Classically, it's going to be in the big toe joint. Classically, it's going to be in men. It's usually not in younger. It's usually in middle-aged to older men. The presentation is going to be a rapid onset of pain, of swelling, of erythema, of warmth in a joint. It's usually going to be one single isolated joint. And in most cases, these patients have had this happen multiple times in the past. In most cases, the second it happens, they already know it's gout. They're already coming looking for their medication. It's diagnosed based on the history, based on the presentation. You can just look at it and you can usually diagnose it. We can also do a uric acid level to confirm it, a joint aspiration, or imaging. All of those are confirmatory tests because we can usually diagnose it based on just the patient story and what we visually see on our assessment. The management of this is going to be NSAIDs, such as indomethacin, possibly ibuprofen. The classic drug we use for this is colchicine, and that's a big test question that we ask about gout. What medication is most commonly used for gout, or used for gout more than anything else? And the answer there is colchicine. And then we also have steroids. Steroids, we might just inject it directly into the big toe, which is generally preferred unless the provider is not too good with those injections, in which case just stick to the oral route, which works just as well. You should be aware that your test might ask you to differentiate between the treatment of acute gout versus chronic gout. In acute gout, where a patient has a gout flare-up, we're going to treat them with NSAIDs, we're going to treat them with steroids, we're going to treat them with colchicine. If the patient frequently has these gout flare-ups, we might want to give them preventative medications so that they don't end up with this gout attacks all the time. And in this case, we have two common medications that we use for this, and that's allopurinol and probenecid. Those are your preventative medications. That's a preventative management for the treatment of gout. Next, we have our nursing notes, and one of these I already said is that it most commonly affects the big joint. The number one thing of patient education for patients that have gout is to educate them on avoiding their triggers. In almost all cases, the patients who have gout, especially once they've had 2 or 3 of these attacks over their life, they already know what triggers it, but you have to teach them to avoid them if they don't know, if this is their first one. Alcohol is a big one. Red meats are a big one. Caffeine. There's lots of different things that trigger these, so you have to teach patients to avoid them. And if they already know what it is, then certainly to just stay away from that. Also, you need to teach them hydration, because if these patients become dehydrated, again, it puts them at increased risk based on the simple patho, the buildup of the uric acid crystals. If there's not enough fluid, then that buildup becomes more prominent. So hydration is very important, and dehydration can also be a trigger for attack. Finally, prevention meds. If a patient does come in with a gout attack and they say, I've had it, this is my 3rd one this year, I want to be on a prevention med, we cannot start the prevention meds such as allopurinol or probenecid during an attack. We have to first treat the attack or flare-up or episode, whatever the patient calls it. But once it's resolved, then we can put them on the preventative medication. Here's our references for this lecture. If you have any questions, please reach out. Hope you do great in class, and we'll see you in the next video.